Tonight, Dr. Adrian is our speaker. He's a graduate of the Loma Linda University School of Medicine with a residency in ophthalmology at UC Davis and a fellowship in vitreoretina at the Kresge Eye Institute, Wayne State University. He's a member of the Retinal Consultants of Orange County in Fullerton. Dr. Adrian will discuss the newest research and technology relative to medical and surgical treatment of retinal loss of vision, which is one of the most common causes of vision loss in the senior population. Dr. Adrian, if you would like to go ahead.
Certainly. All right. Well, thank you all for joining. And I'll go back to this sharing of the screen. All right. So tonight we'll be focusing mainly on age-related macular degeneration, but I was asked to speak a little bit on glaucoma, so I will throw that in there as well. And certainly if you have any questions, you can either type them into the chat or just raise your hand, and Carol's going to help me alert me to any questions. So if during the course of the discussion you have a question, please just go ahead. And that I usually like to do it this way because a lot of people have the same question that's going on in their mind. And so if we answer it then, and then certainly at the end, we can take questions as well. So welcome, and we'll go ahead and get started. I always like to start with what the eye is and how it works. And my favorite way to describe the eye is that it's much like the film of the camera, or it's much like a camera where you have a lens and you have the film that the camera is being exposed upon. And so we like to call the retina like the film of the camera of the eye. And a lot of the light that comes into the eye, 2/3 of it, in fact, is focused by the cornea. And then 1/3 of the light that focuses that light back onto the retina is done by the lens, which, as you know, some of you probably have had cataract surgery. The cataract is your lens that gets cloudy, and that when it obscures your vision, then you go ahead and have that removed with cataract surgery. And the retina, as I mentioned, it's the film of the camera of the eye. And then the optic nerve is kind of like the TV cable that hooks the eye to the brain so that people are then able to see. And here's a good picture of a normal healthy macula. This is actually my macula, and optic nerve and blood vessels and everything like that. And we took this pictures a few years ago, so may not be quite as healthy, but hopefully it still is. So what is macular degeneration, what we're talking about today? So as we get older, there are waste products that develop underneath the retina, and those waste products are a degenerative change, and they're from the rods and the cones and things like that. And when we talk about macular degeneration, there's two types. We talk about the dry form, which is, as mentioning, is kind of a buildup of these waste products. And the wet form is where you have new and abnormal blood vessels that grow. And I liken it to the body's kind of trying to heal these waste products. So these blood vessels grow underneath the retina that just don't function very well and can cause loss of vision. So it is the most common cause of irreversible blindness in the United States. And it is an increasing problem because our population continues to be healthy and live well into their 70s, 80s, 90s. My oldest patient currently is 105, and she turns 106 in just a week. So it right now is affecting about 8.5 million people. And as we get older, the incidence of macular degeneration goes up. And everyone wants to know what are risks of macular degeneration. Well, certainly it's, as we get older, is the #1 cause, but things like family history, your race, Caucasians are at greater risk, gender, women greater than men, things that we can control, things like high blood pressure and smoking are also significant risks for macular degeneration. And this is an unhealthy macula where you can see a lot of blood underneath the retina, and that's this area here. I really like to talk with my hands and walk around a little bit, so you'll see me try to gesticulate, but it's not going to work very well for me. So back to the talk here. We see our life expectancy is increasing, and the rest of the world is catching up to us as we get more and more healthy. And also, here we are at 2020, and we see the numbers are continuing to rise, and we continue to have more and more patients that have this process that's going on. And I like this chart because people always want to know what their risk is at different various ages. And we can see here that by the time you're 85 or 90, your risk of macular degeneration is about 15%. But if you're down at 65, that rate is only about 3%. So definitely is something that happens with increasing frequency as we get older. Now, dry macular degeneration accounts for about 90% of the macular degeneration, and it's characterized by these little yellow deposits underneath the retina. These are called drusen, and they are the waste products that I was describing. This is a late stage of dry macular degeneration that we call geographic atrophy, and also causes vision loss. Wet macular degeneration is where we have those blood vessels that are growing underneath the retina, and there's swelling and fluid and blood that eventually can lead to scarring and a big loss in vision. And it counts for about 90% of legal blindness, even though it's about 10% of the macular degeneration. These numbers are changing a little bit with some of the therapies that we have, which is exciting. And in fact, in Ireland, wet macular degeneration, which used to be the leading cause of blindness, is no longer the leading cause of blindness in that country. And this is kind of a nice figure showing how these blood vessels are coming from underneath the retina. There's a layer of blood vessels there called the choroid, which supplies the retina, and that's where the blood vessels can eventually break through. They break through Bruch's membrane, through the retinal pigment epithelium, and grow underneath the retina, and that's what causes these issues. And so what kind of vision loss do we expect? So once we diagnose patients with macular degeneration, we typically hand them an Amsler grid, and we see this nice box with these squares, and you're supposed to cover one eye, look at it, you cover the other eye, look at it. And patients that have macular degeneration may see some distortions, some loss of vision, and abnormalities in the grid. And that kind of lets you know that because there's fluid and changes underneath the retina, you can have abnormalities in the Amsler grid. This is a good screening tool for patients. And people want to say, well, what is it that you see when you have macular degeneration? Well, one way to kind of describe it is if you're to hold a fist up in front of one of your eyes, kind of close your eye and look around, that the vision you see in the periphery still somewhat clear, but centrally you lose a lot of vision. So people say you can't see faces on TV or faces of their loved ones, and makes obviously driving dangerous. Back to the dry macular degeneration, as I'd mentioned to you before, we have these drusen, and these are underneath the retina that start causing some problems with the vision. Good news for patients that have these drusen is typically it's a more slowly progressive form of macular degeneration. And vision loss is usually slower, and many patients that have this can do quite well for some time. And when we have early macular degeneration, most of the time patients don't even know it. And you may have just a few of these little dots in here. There's the center part of the vision, the macula. And there's not much risk. It's less than 1% developing advanced macular degeneration, defined as wet macular degeneration or geographic atrophy, at 5 years. Now, as this changes and you start getting a lot of medium-sized drusen, or large drusen, now that risk jumps to almost 20% at 5 years. And then also another cause of big problem with loss of vision is what we call geographic atrophy. And it's where there's this loss of tissue underneath the at the retina. And some people describe it as like a eraser that's kind of rubbed out the center. And this too is a big cause of vision loss. And if you have this in one eye, you have a high likelihood, up to almost 50%, that the other eye is going to go to advanced macular degeneration. This is becoming an increasing problem. So here's yet another picture of atrophy. So generalized treatment for macular degeneration. So at any stage, we can always stop smoking, and that's very good. Prevention, some UV sunglasses. For dry type, things like vitamin supplements can be helpful. And there's also a lot of other therapies that don't seem to be beneficial, such as laser. And wet type, we've got a lot of different treatments, and we'll go into those in further detail. For the dry type, we're actually involved in quite a few clinical trials for the geographic atrophy. And we just had some positive results come out that says that with one of the large trials that it is slowing the expansion of geographic atrophy, which is quite exciting for our patients. And so when we talk about vitamin therapy, there's a lot of different vitamins out there. And interestingly enough, for vitamins, there's been 2 studies that have been proven to show that vitamins help disease processes. And both of them are for the eyes. They're called the AREDS-1 and the AREDS-2 studies. And they have a fair amount of vitamin C, vitamin E, beta carotene, zinc, and copper. This is the AREDS-1. And that was then found that the beta carotene was a little concerning because patients that were smokers had a higher rate of lung cancer using beta carotene. So in the AREDS-2 supplementation, they replaced the beta carotene with lutein and zeaxanthin. And with that, there's about a 25% rate of ability to slow down macular degeneration, the dry form, with these pills. So I always say they're really not much of a miracle, but they certainly help. So when you have both the lutein and the zinc, your rate of reduction of progression of macular degeneration is about 25%. So nothing to sneeze at, also not a home run. Can you have too much of a good thing? So everybody says, well, can I double up or quadruple up on the vitamins? Because if I take 1 or 2, that's great. But if I take, 6 or 8, is that better for me? Typically, the answer is no. When you have higher rates of zinc, you can have issues with prostate cancer. And of course, too much vitamin A has been associated with liver toxicity. That's pretty hard to do. It's typically Eskimos that are eating polar bear livers that are very high in vitamin A. So we don't see that much here in the United States. Also, there's some question, was omega-3 fatty acids, where they were beneficial or not. And about 10 years ago, we told everybody, you really should be taking omega-3 fatty acids. They're great. And then we did more studies, and it looks like if you eat fish, like a nice salmon or a Norwegian cod that have high rates of these omega-3 fatty acids once or twice a week, then you probably don't need to supplement as far as the retina goes for omega-3. Now, cardiologists may still tell you to take the omega-3s. Sometimes they help with dry eyes and things like that. But for the retina itself, we don't focus too much of our discussion anymore on the omega-3s. For dry macular degeneration, we've been talking about doing some micropulse laser to reduce the number of drusen. As I was mentioning, we are starting to inject medicine in the eye to slow down geographic atrophy. Sometimes we're targeting some still the complement cascade, which is an inflammation, and cascade in the body, and we're trying to put it underneath the skin of your stomach, almost like patients that have diabetes, and when you treat with insulin and things like that. The intravitreal injections, the injections where we're injecting medicine directly in the eye, much farther along, and like I said, they are showing benefit for those patients with geographic atrophy. Now, when we talk about treatment of macular degeneration, the wet form, in the past we used thermal laser. That wasn't so great because we would burn the center part of the vision and patients would immediately lose vision, but the study showed that that loss of vision was better than if you just let the disease process go along. Thankfully, I wasn't around to do, I was born during this time, but was not around doing these treatments because those patients lost a lot of vision. In the 1990s, they would try surgery to go in there and remove those blood vessels. That wasn't so great either. And then in 1999, we had cold laser. I'll talk about that a little bit later. And then starting in 2005, we started to have the first of these injections where we injected medicine in the eye. Macugen, Avastin, Lucentis, Eylea, and a new one called brolucizumab. So with all these different treatments, we also kind of mix and match and see what we can do to treat this wet macular degeneration so we can both preserve our patient's vision and hopefully improve. Looking more at this thermal laser, we actually go in there and with a hot laser, we're burning these blood vessels. And currently, we don't use it that much, but there are a few instances where it still is helpful. We published a paper several years ago looking when the wet macular degeneration wasn't directly in the center, but near the optic nerve, we would shrink down those blood vessels that were growing, and then we would laser that. And those patients tended not to have recurrence, and they didn't need as many injections to control the disease process. And this is
Doctor,
kind of, yes.
We do have a question in the chat.
Yes.
The question is, what is drusen and how is it toxic? What cells are targeted by drusen if it is toxic?
Okay. I'll go back up several slides here. So drusen, like I said, they are waste products underneath the retina. And what they are is the kind of the bodies of the rods and the cones have these kind of discs. And at night, you shed off your cones, and during the day, you shed off the rods, just kind of the opposite of how you would actually use these. You know, so your rods are for your night vision, you've probably heard, and your cones are your color vision. So your rods are used more at night, and the cones are used more during the day for seeing. And so at night, you shed off these layers so that you kind of have a continual replacement of those. Then the body will reabsorb those and get rid of them. But over time, the body's not able to handle those waste products and get rid of them. And they would then develop into these, what we call drusen. That answer the question?
Can I ask whether drusen itself is toxic?
So yes, I would say that the drusen themselves are these waste products. Sometimes the body gets overwhelmed by them, and the body's trying to get rid of them, and it's an irritant to the body. And so that sometimes is what causes these new blood vessels to grow and turn into wet macular degeneration. Other times the drusen are reabsorbed by the body, and then that is part of the process that could lead to the other diseases that we're talking about called geographic atrophy. So yes, the drusen themselves are not good, and we certainly don't, better not to have those. And that is the onset of dry macular degeneration when you start having these drusen. So this is where we started with a patient that had wet macular degeneration with blood vessels growing, and we shrunk that down with injections, and then we lasered it, and then that patient did much better. So that is one use of thermal laser. And talking a little bit about doing surgery for wet macular degeneration, we go in there and first we remove all the vitreous jelly, and then we reach underneath the retina and we pull out those blood vessels and scar tissue and blood. But the problem is when you pull it out, you're also pulling out all the good cells, the photoreceptors and things like that that help you see. And that's why these surgeries done very infrequently these days. And it's really only if it's in a very favorable location. So next, after we went from the 70s to the late 90s, this treatment was approved, and it's called photodynamic therapy, which is a cold laser. And it's pretty interesting technology where we would put an infusion in through somebody's arm of this medicine and called verteporfin. And then using a laser that was like a cold laser, we would activate it, and that would cause what we call free radicals to generate, and that would close those leaking blood vessels. So how well did that work? Well, I say about 60% of the time, we could stop people from losing 3 lines of vision, and the rest of the time, people still lost vision. So it wasn't such a great treatment, but it was much better than kind of burning out people's center part of their vision where they'd lose it. So sometimes we're able to slow the process down. Back then, when we did this frequently, multiple times a day, you couldn't be out in the sun for 5 days. You get a bad sunburn. Some people got back pain, and it could cause other issues. And then from the cancer literature, basically colon cancer, we learned that when new blood vessels grow, there's a chemical signal that's released called VEGF, which is vascular endothelial growth factor. So you'll hear us talking a lot about anti-VEGF, which is these different molecules to treat VEGF. And what they do is it causes blood vessel growth and increased permeability and leakage. So if you ever had hives or things like that and you scratch your arm, then you start getting some swelling and everything like that there. Well, that's what we call a histamine release. Vascular endothelial growth factor is about 200 times more powerful than histamine in causing blood vessels to leak and everything like that. And in a lot of the disease processes in the eye, that VEGF is increased. And so by targeting that, we have been really able to help people's vision significantly, which is very exciting. We've had this now for about 15, 16 years. And in fact, when I was a fellow back in 2005, 2006, that's when this whole thing just started. So I jumped into this career at just an amazing time where we could really help people's vision, stop it from getting worse and improve it. So here's kind of on the cell's surface, you have these receptors, and then the VEGF molecule binds here, and then it causes a bunch of different changes inside of the cell. And that gene expression then can cause the leakage and the new blood vessels from grow, or cause those new blood vessels to grow, and that causes severe vision loss. So the first one of these that came out in 2005 is Macugen, and it actually wasn't all that much better than the photodynamic therapy. And fascinating, right about that time, out of the colon cancer literature, there's a medicine called Avastin, made by the same company that makes Lucentis, but Avastin is quite a bit more affordable. So about, like I said, in 2005, they started injecting Avastin into people's eyes, and it was amazing. It caused regression of the wet macular degeneration. The vision got better. So these days, I tell patients that 95% of the time we can keep vision the same, and 35% of patients get better vision. And that's so much better than what we had before. So very exciting. But the original study required an injection every month for 2 years. And so I always tell my patients that this is a long-term process where you're going to need multiple injections, but it's completely worth it because this is how we're going to be able to both save your vision and potentially improve it. And so what is Avastin? Well, it's an antibody that blocks that VEGF molecule. And Lucentis is very similar, except it's based on a human antibody versus Avastin, which is based on a mouse antibody. But both work very similarly and very well. Then in 2011, we had this new medicine came out called Eylea. Now this one's a little different because it actually acts and it pretends like it's that receptor molecule like we saw in that original picture a couple of slides ago. And it also kind of holds the VEGF and stops those new blood vessels from growing and eventually causes those new blood vessels to go away. So now we have some new longer acting anti-VEGF agents, like one called brolucizumab. And then we'll talk a little bit about more some of the surgical trials we're involved in for Lucentis, as well as subretinal surgery that we're working on to help as well. About 5 years ago, we were in an eye drop study. Unfortunately, that did not pan out. That was not something that worked. So in 2019, the newest medication came out called brolucizumab, and that was exciting because some patients were able to go, 8 or 12 weeks in between injections. But unfortunately, a lot of these patients started having a lot of inflammation in the eye, and patients lost vision. So that went from a very promising agent. Now we only use it very rarely, maybe in less than 1% of our patients, because we're concerned that they could lose vision from inflammation or even a blockage of the arteries and veins in the eyes. This actually just within the last week or two is approved by the FDA, and it's called the port delivery system. And we actually put a port into the eye, and then we refilled this port, and the medicine, the Lucentis that's in there, lasts for 6 months, and then we exchange it. So I have quite a few patients in this study, and they're doing very well. And instead of patients needing monthly injections, now we're doing these injections about every 6 months where we refill this port. So that's decreasing the number of injections patient needs. So that's very exciting. Another trial we're involved in is for patients that have had macular degeneration for some time. We are actually taking a virus called adenovirus, and that virus has been genetically altered for one of the proteins to deliver an anti-VEGF protein, and we inject that medicine after doing surgery underneath the retina. So then that medicine then can be made by these cells. So we've been quite involved in a lot of research looking at wet macular degeneration at our office, and so published different treatment protocols in order, looking at ways to treat patients that have wet macular degeneration, so we don't have to treat them as often. And when people are doing well, we go longer in between treatments, and eventually you're able to stop treatment if they're doing well. We also looked at patients that had 50 or more of these injections and how well they did. So as I said, this could be a long-term treatment, so we've had patients who have been treated for 12 years and have had well over 100 injections. But the exciting thing is that even though we're seeing them every 5 weeks, we're preserving the vision and helping them still see and drive and still be doing well in society, because as we know, vision is one of our most precious gifts. And then also looked at, other patients, once we stop therapy, how well they do and everything. So that's kind of the button, or the kind of whole kit and caboodle for macular degeneration. I'm going to jump off here into glaucoma. And again, if there's any questions, you can stop me, or if we want to go back into macular degeneration, we can certainly do that. And we can also, I'm going to launch into glaucoma, and we can ask questions about all of those. So What is glaucoma? So far there's no cure yet for it. And we want to obviously detect glaucoma early, and treatment can prevent blindness. So some people call it a silent thief of sight, because whereas with the wet macular degeneration, there's that central loss of vision, glaucoma has this loss of peripheral field that kind of slowly comes in, and you can lose your peripheral field and still it kind of cones down, and then you're just left with a very small central island of vision. And we also like to call it a plumbing problem, because the fluid is produced back here in what we call the ciliary body near the front of the eye. It goes underneath the iris, and then it comes out and it's drained out in the in this what we call trabecular meshwork. That's a healthy optic nerve, and this is an optic nerve that has glaucoma. And so typically there's a slow loss of the peripheral vision before the central vision is involved. And it can really, when it's early, it's just going to be treated by annual eye exams till it gets really advanced. And so you can see that there's a little bit of a loss of the peripheral field. So this is what we call a Humphrey visual field test. So patients, this is not a very exciting test. I've done it before, and it takes a lot of concentration, but you put your chin in a chin rest, and then there's a machine that beeps and flashes light, and you got to push the button when you see the light, and then that's how you are able to detect this loss of visual field. And so this is a healthy optic nerve, and we call this the cup, and then this is the disc, kind of like you're drinking tea or coffee and you've got a cup on a saucer. That as that cup gets larger, then you can start seeing visual field loss, and then when it gets really large, then you have more and more visual field loss. And this is just an illustration like one of the other pictures where we're losing that peripheral field. So now glaucoma is the second leading cause of blindness in the world. And again, the numbers as we get older are getting larger and larger. So we're looking at 80 million people with glaucoma. And since it's slower and it's tend to be caught, not as many people go blind from it. But there's well over 2 million people here in the United States with it, with a good number of those patients losing vision. So what we want to do is, what are some risk factors for glaucoma? Well, certainly family history, your age, race. So African Americans and Asian Americans are higher rates of risk for glaucoma, steroid use, and if you've had trauma in the past. And when you have a glaucoma exam, you're looking at the pressure in the eyes, how thick the cornea is, how the angle looks, how the optic nerves look, and the visual field. And this is just a graphical representation. The fluid is made behind the iris. It comes in front of the lens, and then it goes in front of the iris, and then it's drained out in this stuff called the trabecular meshwork. And this area gets blocked in open angle glaucoma, and that's what causes the problem with the pressure. Closed angle glaucoma, you get a blockage of the outflow, and then that's how you can lose vision with that. And that we really much talked about open angle versus angle closure. There's also childhood glaucoma and other types like inflammatory glaucoma and from trauma and from people that use steroids. So lots of different types. So when you have glaucoma, what are we trying to do? Well, the main thing that we want to do is reduce the pressure, and successful reduction of normal pressure in the eye is anywhere between 10 and 22 when we measure it. And but if some people have a pressure of 18 or 4 or 15 and they're still getting glaucoma damage, that's called low tension glaucoma. And the goal when we start treating patients with glaucoma is to reduce the pressure by 30%. So if you start off with a pressure of, let's say, 30 or so, then you'd want to get that pressure down to 20. But if you had a starting pressure of 20 and it was causing optic nerve damage, then you'd want to get that pressure down to 14. So everybody has a different kind of number where you're trying to reduce that down. And if you can reduce the pressure, then usually it can slow or halt the loss of visual loss and visual field loss. And sometimes you can also restore some vision with things like cataract surgery and glasses. So how do we treat glaucoma? So typically we start off with different glaucoma drops, and there's a lot of them that really successfully lower the pressure. Some work by working on how the fluid is made, and others help the fluid drain better. Laser can help opening that drainage system. There's surgery that can be done to help create kind of a reservoir of fluid, and also implants that can help create a larger reservoir of fluid to help reduce the pressure. And that can help the pressure get better and then slow that progression of visual field loss and help these patients with glaucoma. There's also glaucoma is undergoing a revolution of all these different, surgical procedures that can be done called MIG surgery. It's these mini incisional and microinvasive glaucoma surgery in order to start reducing the pressure earlier, as opposed to having patients on lots of drops. So that you have all these different options where you're putting in different small devices in the angle to try to open up and allow more fluid to drain out, as well as opening up the trabecular meshwork with all these different devices to, again, help the drainage of the fluid. And so for glaucoma patients, we're really trying to preserve their vision, make it easier for them to control their disease, and certainly convenience is what we're looking for glaucoma too. So thank you for listening to this presentation. I know that Zoom is kind of different way of presenting, and I certainly like to wander the stage when I give a presentation, and I'm just forced to only circle my my little pointer here. So I'm going to open the floor to a lot more questions now. And Carol, if you can help me with that, I'm happy to start answering a bunch of questions for everybody.
Okay, if anyone has a question, please raise your Zoom hand or type your question in the chat. I think so far I haven't seen any questions.
Yeah, I know. Sometimes Zoom is not, it's hard to ask questions as well.
Okay, we do have a question. Does Medicare cover the PRT, maybe they meant port delivery system for macular degeneration?
No, it is so new that it's basically kind of hot off the presses. We've had 2 major things that have come out within the last 6 weeks, and literally this just got that port delivery just got approved by the FDA this week, or earlier this week. So I don't want anyone to start holding their breath, because I've had patients before that I've like, oh, I've got a new therapy for you, but it usually takes a long time. And this is going to take a little longer for the FDA, because now that they've approved it, then they'll have to figure out how to pay for it and how much it reimburses and all of those different aspects. So probably several months for that port delivery system to treat wet macular degeneration, and longer for diabetic retinopathy. Like I said, the other big one that came out was for geographic atrophy, another process of dry macular degeneration, and that just has not been approved by the FDA, but their phase 3 data came out that was very positive. So again, they're going to go to the FDA and show them all their data, and hopefully that'll also be approved again, probably sometime mid next year.
Okay, thank you. Another question: what genes are affected in familial glaucoma?
Oh, that's a good question. I think there's one on chromosome 1. Now I'm throwing my mind back about 18 years ago when I used to study this for our tests and everything like that. So that's the only thing that's like jumping to the top of my mind. There's other syndromes, different types of glaucoma, and one that's called this one that's associated with Wilms tumor, aniridia, glaucoma, and some mental deficiency. And that one is on chromosome 11, I believe. So there's a lot of different syndromes associated with glaucoma, and so there's different genetic components. Again, probably a good 90% of glaucoma. Still, we don't really have a great answer for it. It's kind of like high blood pressure. So there's a lot of different factors that go into it, and we don't have a lot of like genetic answers for most types of glaucoma, and we call it primary open-angle glaucoma. And I'd say probably in the United States, probably 90% of patients that are treated with glaucoma.
Okay, thank you. Another question. I'm labeled as glaucoma suspect by my ophthalmologist since 2019. I have high blood pressure, but it's under control by medication. My question is whether IOP and blood pressure is linked. By keeping blood pressure under control, would it also keep IOP low?
That's a great question, and I hear that question all the time. And the answer is no. There's no linkage between high blood pressure and pressure in the eye. So pressure in the eye is kind of regulated by different factors. And so having good blood pressure is good. You definitely want to do that for sure, but it's not going to help glaucoma. And, we talk about being a glaucoma suspect, and what does that mean? Sometimes that means your optic nerves look funny, but you have a good visual field. Sometimes it means that the pressure in the eye is higher. So people will have a perfectly normal optic nerve, but their pressure is 25. So they could be labeled a glaucoma suspect or ocular hypertension. And those patients, typically are just monitored and see how they go.
Okay, another question. Can you discuss the risks with various MIGS procedures?
Again, glaucoma is not my specialty. So, they are an invasive surgery into the eye. And there are a lot of different ones that are available currently. And typically they're being done earlier in the disease process. And so some of those MIG surgeries, anytime you go in the eye, there's always a small risk of an infection called an endophthalmitis. Those are really bad. And typically, anytime we do anything in the eye, that has a risk of about 1 in 1,000. So that's something. One was called the CyPass, was taken off the market because it actually brought the pressure down too low. So if you have the pressure, down at 4 or 5, when normal is between 10 and 22, then you cause what we call hypotony, and that can cause issues with the macula and with the eye itself. And I guess another risk of MIGS is it just does not give you the result that you would like for glaucoma, so that you still may need, the goal is for a lot of these surgeries is to reduce the number of drops required in order to control the pressure. And one thing with glaucoma, when you're putting drops in, they last a certain amount of time. Some drops are 3 times a day, some are twice a day, some are once a day. But the effectiveness of the drop kind of wears off over time. And you may not have good control of the pressure during the night, and you're not aware of it. And so you could still have problems with pressure and the optic nerve being damaged during the evening with just drops alone. So sometimes lasers or some of these MIG surgery may be controlling the pressure throughout the entire time frame. Plus, using lots of drops sometimes get kind of difficult, so if you can avoid using drops, a lot of times, that's patients like that.
Another question, can migraine pain in the eye be a symptom of macular degeneration or glaucoma?
So, some patients will complain of eye pain and like a soreness in the eye. And so we do evaluate to see if the pressure in the eye is high or if there's inflammation in the eye. Those are common causes of eye pain. or if someone scratched their eye or things like that. So the eye can have lots of pain like that. But typically, once we've people say, oh yeah, I've got this soreness in my eye and it's really uncomfortable. And so you take a look and their pressure's normal and there's no inflammation in the eye. And so I always say, it's kind of like you have referred pain. So sometimes your knee hurts, but it's actually coming from your hip or your ankle. Same thing with the eye. You could be having a headache and it's actually kind of focused behind the eye, or you have sinus disease, and sinus disease can also cause pain in the eye. But neither of those are associated with macular degeneration. And once you've ruled out that the pressure is fine, then it's also not associated with glaucoma.
Another question, does dry macular degeneration usually progress to wet if you have dry by age 55?
So dry macular degeneration has about a 15% chance of progressing to wet. You can reduce that risk with the eye vitamins. So no, 85% of the time, dry stays dry.
Okay. Does exercise reduce glaucoma pressure?
Not in any meaningful way. The other one that people love to ask is, what about marijuana? And marijuana can, but you have to smoke it about every 2 hours in order to maintain the pressure lowering effect. So usually that's, for most people, not a very good solution if you want to enjoy life.
Has it been found that NSAIDs or plane flights affect macular degeneration?
No. Yeah, actually there was a study out of Australia, not NSAIDs, but aspirin. And in Australia, they found that patients that took aspirin had a higher rate of wet macular degeneration. So that caused quite a stir, probably about 12 years ago. But then we went back and looked at our data for the AREDS2, and we had found out that no, aspirin is fine to take, and it's not increasing any risk of what we call wet macular degeneration. So then most people are on aspirin for a great reason, for their heart and, thinning their blood and things like that. So don't worry about taking aspirin, and certainly don't worry about taking NSAIDs. And plane flights, yes, please. I guess most people aren't doing too much plane flights right now, but hopefully as the world opens up some more plane flights.
Okay. Are there therapies based on preventing neurodegeneration applicable to glaucoma or macular degeneration?
So for neurodegeneration, a little bit more in the glaucoma space. They are looking at trying to slow some of the progression of glaucoma, and they are also looking at some implants to try to do that. One is called brimonidine, which is an alpha-GAN drop, and there's the thought that there's like a neuroprotective effect for that. So typically, if you're one of my patients, that's one of my favorites to put people on, because it doesn't also cause issues with the retina, like macular edema. So yeah, that's kind of, I like alpha-GAN as one of my go-to. They don't know that I support their drop, but I like the fact that it may have a neuroprotective effect. As far as macular degeneration, not so much. We're kind of looking at what I said, the inflammation cascade inside of the eye for dry macular degeneration of the geographic atrophy. And for wet macular degeneration, we're looking at different targets that cause the wet macular degeneration to progress. Oh, someone raised their hand.
Oh. Let's see who that is.
It's Roberta.
Roberta.
But I don't know.
Go ahead, Roberta.
Okay, I sent this question in. I had cataract surgery, and now I need a YAG capsulotomy because my vision is a little bit blurry in both eyes. However, there is a small retinal problem evident in one eye. Should a retina specialist be seen before going in for a capsulotomy?
Typically, a capsulotomy has very low risk. It's almost zero. Yes, there's a very small risk of retinal detachment and things like that. But it's very rare, probably less than 1 in 10,000. So on the whole, a YAG capsulotomy is in office laser procedure to open the bag that holds the new lens in place. And, if I would just kind of trust the instincts or the clinical acumen of the ophthalmologist that's treating you. And if they don't feel like the retina specialist like myself needs to see you, then I would say, oh, okay. And then after they do the YAG capsulotomy, if there's, evidence that there's more retina problems, then they may say, oh yeah, it makes sense to go see a retina doctor.
Okay, thank you.
Uh-huh.
Another question, is the high dosage of vitamin E in AREDS 2 a problem when also taking statin drugs?
That's a good question. Off the top of my head, I don't know that answer.
Okay. How often should pressure be checked in glaucoma?
So that is actually dependent on the disease state. So if, it's a very advanced glaucoma, a lot of times patients are seen every 3 months and making sure that the pressure is okay. If it's moderate glaucoma, it's probably every 6 months that the doctor will see you. And if it's mild or like an ocular hypertensive or a glaucoma suspect, it may be every 9 months or once a year or something like that. So yeah, pretty infrequently compared to things like blood pressure and things like that.
Okay. What are the differences between Nevanac and Bromsite to treat retinal swelling?
Yeah, I mean, they may work sometimes depending on the disease process. Sometimes you may see a little effect of one of those drops, which are both like NSAIDs in the eye, and they may reduce the swelling a little bit, not always. And I think Bromsite is once a day and Nevanac is 3 times a day. It's probably a lot of times, we say, oh, maybe we can try after surgery to be on one of these different drops. And a lot of times the insurance says, oh no, that drop's way too expensive. We should use the generic, which is 4 times a day. So, it's kind of like the difference between, Advil and let's say Aleve or something like that. So, but it's basically how often they need to be dosed and price.
Okay. Blood vessel ruptures in the eye on a regular basis, let's say once every 6 months. Is it a precursor to any eye problem?
Typically, when people are talking about that, they're talking about the blood vessels that break underneath the what we call the conjunctiva, which is on the white part of the eye, and it looks like a big kind of red area. We call it a subconjunctival hemorrhage. It's basically like a bruise, and sometimes people have these more often if you take blood thinners, and can be promoted by things like coughing and sneezing or rubbing the eye, or if you have allergies. I got one once when my contact lens that I wear kind of sliced one of my blood vessels, so I had a small one. And no, they are fine to have. Very rarely are they indicative of any sort of like clotting disorder, like your blood is too thin. And so if you take a blood thinner and it happens, then typically it's nothing to be concerned about.
Another question, would the initial onset of dry macular degeneration impact the possibility of cataract surgery?
No, we recommend cataract surgery all the time in patients that have macular degeneration.
Okay, there are no more questions in the chat right now, and I don't see any hands raised either. I think that is probably it. Well, thank you so much, Dr. Adrian. That was a really interesting talk.
You're welcome. Hope everybody enjoyed it.
Oh, I think they did. You can tell that was a lot of questions, a lot more questions than we generally have. So thank you very much. We appreciate you giving of your time.
You're welcome. Hopefully one of these days we can do a live one of these eventually.
Oh, we hope that also. And
right,
just
we're good.
Sorry.
Oh, go ahead.
Oh, I was just going to say, our talk next week, November 3rd, will be at 9 a.m. And the topic will be exercise, diet, nutrition, and fall prevention. So we hope we'll see everyone then. And once again, thank you so much, Dr. Adrian.
You're welcome. Everyone have a great night.
You also.